Hello, and welcome to the Somatic Approaches and Therapy Summit. My name is Dr. Chinwé Williams. I'm a licensed and board certified EMDR therapist. I also serve as a consultant for schools, nonprofit, corporate, and faith-based organizations around mental health and wellness. I have been honored to serve as a faculty member at a couple of different universities, Rollins College, Georgia State University, Argosy University, and the University of Central Florida. I also wear a lot of hats. I'm an author of 2 books. One of my books is a book for parents and caregivers and leaders to help young people manage anxiety and despair. It's called Seen, Healing Despair and Anxiety in Kids and Teens Through the Power of Connection. And I'm so excited to share that I have an upcoming book set to be released in May 2025 called Calm, Courageous, and Connected. I am so excited to be here with you today. We are going to talk through lots of different practical tools and strategies, interventions, such as EMDR, that are somatic based to help you support your clients who are experiencing deficits, shame, and trauma from poor or insecure attachment in their childhood. So I'm glad that you are here. Let's begin. So the title of our presentation today is Somatic and EMDR Interventions to Support Clients with Shame and Trauma Due to Attachment Wounds. I want to share just a little bit about my background in this area. So I am trained in a model of EMDR that some of you may be aware of called SAFE. So SAFE is an acronym that stands for safety and attachment, focused eye movement, and desensitization. So this is a model that was developed by Deborah Kennard, and Deborah studied for many, many years under Francine Shapiro, who developed EMDR. And she was a trainer, and she was also a body-based practitioner, and she really brought these 2 models together. We'll talk a little bit about EMDR very shortly. And the basic training already had somewhat of a somatic focus, but Deborah really elevated this. So this is a model that I am trained and certified in, and it addresses, I find, some of the more common blocks that therapists tend to see when working with clients who've experienced developmental trauma. So let's begin with what we're going to cover today. We're going to really dive into the detrimental effects of early trauma. We know that early trauma impacts one's mental state, ability to emotionally regulate, and also important relationships. We're going to talk about key principles of this model that I've been working in for many years. We'll call it somatic EMDR. And we'll dive into all of the particulars around it that will be relevant for your work. And then finally, I'm going to share very specific interventions and strategies that will help you to support your clients who've experienced early trauma that have led to shame and difficulties in interpersonal relationships. And we also call this attachment wounds, right? But let's begin with level setting. What's trauma? Right? Most of you here likely know exactly what trauma is, right? And we also know that there's not a universal definition for trauma. Most of us will agree that trauma involves an experience, right? Not an event, but an experience in which individuals who are exposed to or witness events that are overwhelming to them, overwhelming their ability to problem solve, overwhelming their ability to cope. This is a very difficult experience. And so I've taught trauma for over a decade at a couple of different universities, as I've mentioned. And one of the ways that I like to describe trauma to my graduate students is in this framework, the 3 E's of trauma. So trauma is an event or a series of events or a set of circumstances that can be experienced by an individual or individuals in the sense of collective trauma as physically or emotionally harmful. It can at times feel life-threatening, and it also has lasting negative effects. So that's the third E, which can encompass significant alterations to one's experience of self, the way that one relates to other people, and also their world. So experiences of trauma, we would like to think that it doesn't happen quite often, but that just isn't the case. Experiences of trauma are actually quite widespread. Traumatic events are extraordinary, according to Dr. Judith Herman, not because they occur rarely, but actually because they overwhelm the ordinary human adaptations to life. So many of you are familiar with Dr. Judith Herman. She wrote a seminal book called Trauma and Recovery. That's the book that I've used in teaching trauma to graduate students. And so Judith is a leading expert in traumatic stress, abuse. She served as an associate clinical professor of psychiatry at the Harvard Medical School. And she knows a little bit about what she's talking about. I'm going to share just a little bit about how she really ushered in the diagnosis of CPTSD in just a little bit. So we owe a lot to Dr. Herman. So again, experiences of trauma are not, extraordinary because they're rare, but because they really impact our sense of self, our ability to relate to others, and the world. So we are very familiar and not super far removed from the experience of the COVID-19 pandemic. So while traumatic events can happen to anyone, we know this because of COVID, when most of us were affected in some capacity. As someone who started their career, I started my career working with teenagers. I saw firsthand in talking with families and teenagers that I see, and my own teenager, how the pandemic really impacted young people. It turned their lives upside down, and many of us adults experienced that turmoil also, right? Especially working in the field of trauma. We experienced it vicariously through our clients and maybe our own direct experiences. So studies tell us that we're more likely to be traumatized if we have already undergone a traumatic experience. That's number one. The second thing is if we are already under an extreme stress load. And then the third piece is if we've been traumatized before during childhood. So, friends, I don't have to tell you that the pandemic impacted adults, young adults, teenagers, and it left a lasting effect for a lot of people, for us collectively. But the trauma that happens when we are really young just has a different flavor. For many of our clients, trauma began very early in their life with devastating experiences of abuse or neglect. We know that trauma that happens early in life can be the most damaging form of trauma because these early experiences are typically with caregivers. And we know from brain science that it actually changes the way that the brain develops and can impact all areas of functioning, even into adulthood. So for many of our clients, early experiences of trauma or neglect impacts their ability to keep themselves calm. And for some of my clients, they don't even remember being able to do that because they were never taught that, right? And so it impacts the sense of safety in one's mind and also in one's body. And trauma also impacts your closest relationships. So we're familiar with the term complex trauma. So complex trauma really is an experience of repeated chronic exposure to traumatic experiences, typically over the course of years. And these symptoms are complex, hence the name, because again, it's usually at the hands of a trusted adult or a caregiver, someone who was supposed to protect, right, and not do harm. So again, Dr. Herman, in her seminal book, Trauma and Recovery, actually summarized her clinical observations and research with female survivors of intimate partner violence. In the book, she calls it domestic violence, and females who have experienced sexualized violence, and many who experience child sexual abuse. So back then, when the book came out, she proposed the diagnosis of what she called complex post-traumatic stress disorder, or CPTSD. So we now know that after many, many years, decades of practitioners and researchers really advocating for CPTSD to be a diagnosis, it finally has happened in the ICD-11. So it's important to have an understanding of the effects of early trauma, because we know that these experiences often occur at an early time in development where one's brain is still forming. And that has a way of significantly compromising the mental and emotional development of an individual. So I like to explain it this way. We can be traumatized or experience trauma, due to many different things. So we can be traumatized by a house fire, of course. But when you're traumatized by your grandfather or by a clergyman or woman, it's a whole different thing. So that is the nature of complex trauma. It impacts not just our relationships, but actually impacts the way that our brain develops. So to understand the real impact of trauma, we really need to understand how the brain and the body responds to stress. So this will be just a quick primer, a quick review for many of you. Exposure to complex trauma leads to structural and functional changes in our brain. And these functional changes really include an overproduction of stress hormones that starts to wear down our immune system. And it can actually lead us to have a big difficulty, right? Big problems with tolerating stressful situations or feeling like we can recover from stressful situations that we encounter every day in life, right? So essentially, instead of being in a calm, peaceful, regulated state, many of our clients report constantly being in survival state, right? And then there's this experience of shame. So that's a big one, right? I'm thinking of a client that I just saw this week. The experience of trauma, especially when it rises to the level of PTSD diagnosis, it can unlock so many different emotions, right? Fear, anxiety, sadness, deep sadness, anger, even just aggression. But there's another emotion that I find to be one that sometimes gets overlooked, right? Or we think of it as guilt, or, they're taking, too much responsibility. But shame sneaks in over time and can be difficult to really address in the therapeutic setting. So shame has recently been included in the diagnostic criteria for PTSD and the DSM-5, and it's under the umbrella of persistent negative emotional states, right? That fits. While chronic shame can be experienced or can come up from a variety of sources. You can feel like you're not meeting your family's expectations. I work with a lot of parents, right? They often feel there's a huge amount of parental stress. They feel like they're not measuring up, they're failing. We can experience shame from societal expectations, right? What it means to be a woman or a mother or a working mother. We can experience shame from discrimination. But what's very clear is that this experience of chronic shame that is connected to trauma typically stems from early childhood wounds or attachment wounds. So there's a strong correlation there. The experiences of chronic shame or chronic anxiety with childhood or complex trauma. So the way that shame typically presents in my clients, and probably yours, are thoughts and feelings of being flawed in some significant way, being inadequate or perceiving themselves to be immoral or defective because of what has happened to them. And so shame has a way of being very destructive to our clients. It damages the way that they see themselves, or their self-image, their self-concept, certainly their experience of self-efficacy, right? Can I do this? Why would anybody allow me to do this? Am I worthy to do this? Some clients may ask. So that's what shame does. It makes you feel deeply unworthy of good things, right? That you have earned, that you have a right to. And we also know that in certain cases with childhood trauma, shame can be stored in the body and presents itself as physical sensations and tension and discomfort and even pain. I will share with you how I work with shame somatically later in the presentation. But as therapists who are working with clients with complex trauma histories, it is so important not to ignore this emotion that can really destroy or debilitate the important relationships and the way that our clients view themselves and view other people. So Alan Shore has written extensively in the field of trauma and childhood trauma. So he is a developmental neuroscientist. And what he says is that emotional dysregulation can be caused by both underregulation and overregulation. So I'll get into that a little bit later, but here's his quote. Loss of ability to regulate the intensity of feelings is the most far-reaching effect of early trauma, right? So when our clients are struggling to feel at all or are feeling way too much, they're flooded with overpowering emotions. One of the things that I really instruct the folks that I consult and my supervisees and my graduate students is to view their experiences and their reactions as adaptive, right? These are our clients' strategies for avoiding in some cases, but usually coping, right? Coping with stress. So my friends, this is why I believe a somatic and an attachment-focused approach is important, because it takes into consideration the difficult relationship patterns. So we'll go over attachment styles very shortly, and just typical relationship patterns that present itself as habitual behaviors or habitual patterns. And so what I say to my clients sometimes is that, the poor or insecure attachment that you experience or that you didn't experience secure attachment can sometimes manifest or present in our physical bodies. And then sadly can sometimes keep us or prevent us from getting the thing that we want the most. And in the case of many of my clients, and I'm sure many of yours, it's healthy, meaningful, stable, secure relationships. So speaking of relationships, trauma's impact on relationships is quite profound, right? So often the most violent events, I say this to my clients, often the most violent events are not always the events that have the deepest impact, right? Because there'll be a comparison. Well, I didn't go through this, right? And I wasn't harmed, or he didn't fully do that. And I know someone else that had a similar experience, and, he or she was harmed, much more significantly, right? That comparison. I wasn't really physically harmed. Well, the most violent or physical experiences don't necessarily have the deepest impact, right? Following interpersonal, developmental, relational trauma, there's an experience of just being afraid to be in relationship. So trauma due to deliberate harm by others is, again, particularly damaging. And it's also known to increase the likelihood of a PTSD diagnosis. So our clients learn to expect danger, betrayal, or potential harm within new or old relationships. And sometimes they're also afraid, and simultaneously afraid and yearning to develop that closeness, right? Some of our clients who have attachment anxiety may struggle with feelings of abandonment. And so that shows up in, being maybe overly dependent, or in their words, clingy, on others, or needing validation from others, right? Needing to constantly be reassured. And then we have clients who have more of an attachment avoidance style that may start to distance themselves just as they're feeling close and comfortable with someone, right? And that's a way, again, we want to see this as adaptive. That is a way to guard themselves from the potential of hurt. So let's take a closer look at attachment styles and patterns, especially resulting from complex trauma. So complex trauma results in difficulty managing big emotions, regulating powerful emotions, and feeling secure in our relationship. So an attachment pattern is the model of relationship, or the blueprint by which many of our clients design and show up in their relationships. So we know that secure attachment is the ideal condition, the ideal experience, where our clients are able to establish and maintain meaningful relationships, set healthy boundaries, ask for what they need, accept help when offered, right? And then their insecure attachment experiences, right? Anxious attachment, avoidant attachment, disorganized attachment. And many of us are very, very familiar with that and how that shows up in our clients. So when you have a client who's anxiously attached or has an anxious attachment style, they have a fear of rejection and abandonment, right? They may constantly seek validation from external sources, right? Someone outside of themselves. So that's a huge part of the work that we do when we're working with complex trauma, is right, helping them to recognize their own voice and to trust their own voice, right, and what they need. And then clients who have avoidant attachment styles, which is another type of insecure attachment, they may have difficulty building or establishing meaningful relationships. Again, fear of intimacy, but deep down, there's insecurity there, right? Fear of being hurt or being exposed or being vulnerable. And then we have disorganized attachment. That's the third type of insecure attachment. And our clients with disorganized attachment may exhibit inconsistent behavior even with us, right? And that comes from a place of just, I don't know that I can trust you. You're saying all the right things. Yeah, you're showing up consistently, but I've never really had a model for that, right? And so when you have insecure attachments coupled with a less than optimal, we'll put it that way, or even harmful childhood, it impairs the natural growth of integration, and it can actually lead to many, many different mental health problems and conditions, chief among them as a symptom, the ability to self-regulate. So these are patterns that you are already likely seeing in your office. And if it shows up, I say get excited, right? Because that means there's an opportunity to do some good work. And so safe and responsive, integrative relationships, right? Those relationships that we can cultivate in the therapy room promote what Dan Siegel calls neural integration, right? And I believe that utilizing a somatic and EMDR attachment-focused approach can help to cultivate that integration. So, and I pretty much said as much already, right? Incorporating aspects of the EMDR protocol. So, by the way, if you're here and you're not trained in EMDR, that's okay. These are tools and techniques and strategies that you can use without being fully trained or not even having much exposure. I'll share a little bit about EMDR in this training, but pulling from some of the protocol and then also adding resource activation or cultivation from Laura Parnell's work, and then folding in somatic practices, I believe offers clients a way to integrate and strengthen their attachment systems, especially clients who've experienced developmental trauma. So I'd love to share just a little bit about EMDR. Should you be interested in digging a little bit further, some of you who are watching right now are very familiar with EMDR, but just giving you some highlights. So EMDR was developed by Francine Shapiro in 1987, and she discovered the positive effects of bilateral stimulation, as the story goes, walking in the woods, right? And what she noticed is that some of the disturbing thoughts that she experienced started to disappear, right? As she was looking from left to right, right? And that the negative charge, right, that intensity started to reduce or disappear. And so then she shared this information with her friends, and she noticed the same thing. And she was fascinated by this, right? And she wanted to test it out on her friends, her colleagues, family members, and they were successful. She experienced success in observing reduction in negative emotions and powerful emotions that were limiting to individuals. So eventually she worked with approximately 70 different people in a 6-month period to develop what is now called EMDR. Initially, it was EMD. And so from there were other control studies that were conducted over time, and there was a protocol that was fully developed called EMDR. In 1989, the Journal of Traumatic Stress published the first controlled outcome study. We know that EMDR is an effective treatment for achieving results very, very quickly for many, many clients. And so I think just a few years ago, I read that there were 24 controlled trials. So I know that there's so many more studies since then that really does support the positive effects of eye movement desensitization and the treatment of emotional trauma and other difficult life experiences. So EMDR is now placed in the A category, right? We like A's, right? As strongly recommended for trauma treatment by the Department of Veteran Affairs and the Department of Defense. And so just a few years prior to that, there was a study with military veterans that noted that after just 12 sessions, there was a 77% remission in trauma symptoms. So that's actually pretty amazing. So EMDR works, and people often wonder, well, how does it work, right? So there is a model that Francine, the developer, proposed in 2001, and this model is called the Adaptive Information Processing Model. And essentially it states that the body in the mind have a natural processing system. And the way that I explain it to clients is think of, a file with lots of different folders. And our natural processing system controls, filters, and reacts to incoming information, right? And the information is our memories, right? Our memories of our life experiences, and memories are stored in associated memory networks. Again, think like a file cabinet, and really do become the basis of our attitudes, right? The basis of our beliefs and our perceptions. So those early memories can contribute to health, but they can also contribute to dysfunction and even pathology. So trauma causes a disruption in the normal adaptive information, which can cause a variety of different traumatic related symptoms. So when something disturbing happens to us or our clients, it gets stored in the brain in a different way, right? It's not the normal filing system. And because it's stored as raw, unprocessed material in a different way, sometimes our human system feels like when we experience something that's reminiscent of the earlier trauma, it feels like it's happening right now, right? So many of our clients that we work with today are living in trauma time, right? So that's why we constantly remind our clients, you are in the here and now, right? Not the then and there, but the here and now, not the then and there, right? So processing of the memory. So transformation is possible. That's, we have many, many good news to share, right? A lot of good news to share. Processing of the memory can cause an adaptive shift. So clients are able to integrate sense of time, how old they were at the time, those behaviors and their sense of self. And so EMDR is just one way, I think a very powerful way that helps to move the storage of old, raw, unprocessed memories to a more functional part in the brain. So that is how EMDR works. Very quickly, there are 8 phases of EMDR therapy. Throughout the presentation, I'll highlight just a little bit of what we can do with the history taking, preparation, assessment, really just understanding how it's stored in the body, in the memory system. And then I'll talk very briefly about desensitization. But those of you who aren't trained in EMDR, please do not be confused or overwhelmed or intimidated by this, but just wanted to sort of give you an idea that EMDR really is not about steps. It's more so about phases. And these phases are really important, but they don't occur linearly. All right. So EMDR, again, is a well-researched treatment for trauma, PTSD, mood, and anxiety issues. We also know that there are some research studies that point to the effectiveness for somatoform disorders and also medically unexplained symptoms, especially when the onset of the symptom was linked to a traumatic experience. So let's talk a little bit about top-down versus bottom-up approaches. I am sure that this is a term that you are very familiar with. So body-oriented therapies and EMDR are considered bottom-up. I will say EMDR is actually considered both. So top-down approaches to processing or healing trauma are more cognitive. So they rely on information that comes through the frontal lobes. And this is about 25% of our actual lived experience. So top-down approaches are effective, but I would say slower when you're dealing with trauma, especially developmental trauma. And so that's just something to keep in mind. And by the way, I use a variety of top-down approaches. So bottom-up, on the other hand, tends to be experiential, right? So it uses the body to engage the lower parts of the brain, the limbic system, really the place where trauma lives. And by the way, this is about 75% of our lived experience, and it is essential for trauma recovery. So again, EMDR uses both, but it's primarily a bottom-up process, which is why we see such rapid shifts in the way that memories, traumatic memories, are stored. So somatic therapy involves helping one to understand how their nervous system is functioning and how it was actually impacted by the traumatic event. And I would add how the patterns in the body were created as a way to deal with what happened. So somatic experiences, or I should say somatic practices, helps our clients to recognize and release stored trauma that's been trapped in the body. So I'll share many different interventions. But by integrating both techniques, pulling from the EMDR protocol and pulling from somatic therapy practices, I believe that that offers clients a really comprehensive path toward healing, especially the physiological, the psychological, and the physical aspects of complex trauma. So key principles of somatic therapy include the following. First and foremost, safety. So these are what I have identified as sort of guiding principles for somatic EMDR, bringing in the attachment focus, right? That's the way that I was trained. So the first is safety. Throughout treatment, our clients must feel a difference, right, from what they felt during trauma time or what they feel almost every day. They need to feel emotionally safe. They need to feel physically safe in order to effectively participate in any form of treatment. So trauma, specifically complex trauma, often involves violations of trust. So it is so important for therapists to do the opposite, right? So trust is paramount, and we'll dig into that very soon in our presentation, just a little bit more. So the therapeutic alliance, to me, is also a key principle or a key intervention, something that we really want to pay attention to. What enhances the therapeutic alliance is offering clients choice and voice. I say that to my grad students all the time. We have to offer our clients choice and voice. Many forms of trauma involve the individual not having a choice and being limited in their voice. That's why somatically, many clients will experience tightness in their throat, or while you're processing with them, they'll say, I'm choking on my words, or I feel a lump in my throat, right? So clinically speaking, we want our clients to have a voice. We want them to be active in their in the participation of their treatment, right? We want it to be collaborative throughout. And we also want to offer compassion, and I'll dig into compassion very soon. And the way that I offer compassion, even as a mindset, is to believe that every client that I am working with, I am assuming that they want to be better. Right? I'm assuming that they want change. And I'm assuming that what led them to my therapy office, though upsetting to them or to the people that they love, was indeed adaptive. So that's really important. And then another principle is just recognizing the mind-body integration piece. Many trauma survivors feel very disconnected from their bodies. And so utilizing somatic EMDR approach helps clients to reconnect to their body safely. And so I have found that for many, I've been working for 18 years. For many of my clients who experience complex trauma, if they are entering into therapy for the first time, or maybe they didn't have a therapist that integrated mind-body awareness, talk therapy just isn't that helpful. It's fine. They feel like they're getting something off of their chest often, But somatic therapy, and by the way, I utilize talk therapy. And what people don't realize is that somatic therapy also includes talk therapy. But that's again, a top-down approach, right? If that's solely what we are utilizing in our approach to heal trauma. But what I find to be helpful is to incorporate body awareness, somatic inquiry, especially for those who haven't had much success with talk therapy. And unlike traditional talk therapy, what somatic EMDR offers is the acknowledgement that both the mind and the body can facilitate deeper, lasting healing. And then another principle is emotional regulation, something that is deeply, deeply impaired following the experience of complex trauma. So I always tell my clients, pay attention to your body's signals, right? Your body's always communicating to you, even when it's like, you're like, hush, stop, right? Because you're flooded with so many emotions and physical sensations. But what this approach does is it helps clients to better emotionally regulate, which helps to reduce their symptoms of anxiety and even anger, and improves their overall well-being. And so repairing neural networks is also what we do within EMDR through the adaptive information processing model. And we'll talk a little bit about how we do that also through resourcing. All right, so safety, the importance of safety in the therapeutic relationship cannot be overstated. Establishing this safe, secure relationship is paramount in all therapies, in my opinion, but especially when working with clients with complex trauma histories. And what we see, and what I find remarkable in my work, is that emotional reactions to the trauma shows up within body sensations, right? Certainly, negative thoughts or cognitions and beliefs about themselves and about others, right? We see that. But what's remarkable, this is the part that's remarkable, is that we can also see that be altered, right? Or modified through a close relationship with a compassionate other, right? So that is what Mary Main calls earned secure attachment. Even if you didn't have secure attachment, that experience can be gained, and it can be gained through the therapeutic relationship. So safety is established and maintained in a number of different ways within the therapeutic relationship, explicitly and also implicitly. One key way of maintaining safety is just to attend to what Dan Siegel calls the window of tolerance. When clients are above the window of tolerance, they may feel hyper-aroused with powerful emotions such as anger, anxiety, overwhelm, panic. And this can present in their relationships as defensive or constantly agitated or frustrated. But then when clients are below the window of tolerance, they may feel shut down, numb, dissociated, right? Fatigued. They may report feeling depressed. They may have difficulty setting boundaries, right? They may express feelings of helplessness or powerlessness. What can we do within the therapy room to help clients to get back within the window of tolerance and to maintain that therapeutic alliance? So neuroscience tells us that gentle eye contact, right? Gentle vocal tones, saying supportive, compassionate statements. I'm here with you. You're not alone. That was then and there. This is here and now, right? Addressing fears that clients have, encouraging that, right? Sometimes we'll sort of slip into the mode of, we have a protocol, right? Or we even have a script. We have step 1, 2, and 3, and we know that this works, that we're not focusing on the fear in the client's eyes when you even say, notice your breath, right? So not waiting for the client to ask questions, but eliciting those questions, asking, what I just shared my plan of what might help. What's coming up for you? What's landing for you? What feels scary, right? That's a way of creating that safe container. What might help you to feel safer, right? Or more safe. Having that non-judgmental, empathic posture, which is critical for clients who are dealing with shame, saying whatever's coming up for you is okay, right? You are welcome here. Something that I say quite a bit is, pulling in IFS parts work. Every part of you is welcome here. The angry part, the part that's skeptical, the part that doesn't know if you trust this process or even me, right? The tired part of you, the weary part of you, every part of you is welcome here. And then finally, being able to regulate our own strong emotions is critical to the work that we do with healing complex trauma. So let's talk about some different strategies to help our clients to process and heal from trauma and to even just deal with the distressful, powerful emotions and those states that can just really, make our clients feel like they're being thrown overboard, right? Or they're drowning. I hear that a lot. So remember, recovery involves a reversal of the traumatic experience. So we have to understand the dynamics of trauma, which is why I wanted to give, a little bit of a review in order to be able to provide the opposite experience. So trauma involves feelings of powerlessness. So it's important to empower clients with tools that enable them to ride the wave of those big, powerful emotions. And because trauma is stored in the body, we have to address the body, right? Somatic, soma means body. So somatic-based strategies will help our clients to actually widen their window of tolerance to be able to process difficult things. So these are strategies that you can use if you're not an EMDR therapist, if you're not practicing EMDR, whatever model of trauma processing that you utilize, stick with it and consider folding these in prior to processing difficult traumatic material, or again, building safety and widening your client's window of tolerance. So here are some practices that I am going to review with you. Again, a way for clients to begin the process of healing or just get through a difficult crisis, a difficult moment, and feel like they have the tools to do so. So we've already talked about therapist attunement. That is going on throughout. We're going to talk about resource techniques. We're going to talk about sensory motor modifications, and we're going to land with self-compassion, which is not just an idea. This is a way that you can deal with shame somatically. So excited to go over all of these things. So let's begin with resourcing techniques. So I'm sure many of you are familiar with Laura Parnell's work, who it was an EMDR certified trainer and also got permission from Francine Shapiro herself to modify, do it in her way. So she created a whole protocol around resourcing. And again, you don't have to be an EMDR trained clinician to utilize these techniques, but these techniques are important because our clients need to feel stable. Right? Stabilization is the first phase in any trauma recovery model. So before it's safe enough for our clients to access any upsetting material, let alone talk about it, it's important that our clients feel sufficiently resourced, because otherwise any recall of traumatic material can be overwhelming, if not re-traumatizing. So it's important to teach basic coping skills, breath work, encouraging our clients to get outside and interact with nature, move their bodies. We know that traumatized individuals have overactive nervous systems. And so there's an exaggerated startle response that can sometimes feel chronic, right? So we want to help our clients to feel stable in their bodies. So we want to resource them. So resourcing refers to identifying and instilling positive experiences, beliefs, and skills in order to help our clients to cope with difficult reactions and even prepare them for deeper level trauma processing. And so we can resource our clients vis-a-vis imaginal or imagination, visual exercises. And what I find really, really impactful is adding butterfly taps or a butterfly hug. So again, resource tapping can be done as a treatment technique that's integrated into the work that you're doing currently. Or it can be used as a method of preparing clients for trauma processing via EMDR or any other trauma recovery model. So peaceful, healing, calm place, nurturing protective or protector figures, and then again, butterfly tapping are common resources. And think of these as stress management tools, right? That we teach our clients to be able to establish safety and reinforce positive neural networks that will enable them to cope when life gets hard and heavy. That's what's missing, right? And so we don't want to wait too long hearing their story, going over the intake, doing a bunch of assessments. I provide this resource day one, the very first session. So originally when EMDR was developed, safe place, or I call it peaceful place, calm place, healing place is how many therapists identify it now. But it was originally called safe place, and that was the primary resource. We now know that there's so many more. So I want to just, point out that it's important to do any of these resources prior to any trauma processing, regardless if you're doing EMDR or anything else. So there really are an unlimited number of resources. I've highlighted 3 that I find to be most helpful with my clients who have had complex trauma histories. So let's just start with peaceful, healing, calm place, right? And so what I like to do is to teach my clients to butterfly tap first, right? I introduce that first before I introduce the peaceful, calm place resource. And so I'm going to introduce it to you. So I invite you to cross your arms, place your arms across your chest just like this. Sometimes it's just fun, especially with younger clients, really with anyone that's young at heart, to teach them just sort of, to interlock their thumbs and play with their fingers as if this is the butterfly's wings, right? And I talk to my clients about, just being gentle and it being, feeling natural, sort of gently tapping each shoulder. If you do it this way in a rhythmic fashion, just sort of alternating, right? And then as my clients are tapping, I invite them to either close their eyes or lower their gaze. I'm going to go ahead and go to the next. Oh, not quite yet. I've got the butterfly there, but let me go back to this slide here. So I invite them to either close their eyes or lower their gaze and just breathe. Just notice their breath. Invite a deeper breath if it's comfortable. And then focus on the sensations of the taps. So we just start right there. So once they know how to tap, often this does the trick, right? They're already feeling down regulated. They're already breathing deeper in their abdomen and not in their chest. But then this is when we add the visualization. So let's start with peaceful, calm place. And here's just a sample script. And I invite you to make it your own. Spend a few minutes going inside and quieting your mind. Imagine that you're at a place that feels peaceful, healing, calm, a place that you feel most like yourself. I'm going to insert that clients recall beach experiences. That's very common. Being at grandmother's house, being in a cabin in the mountains, a cottage overlooking a lake, right? Or sitting on a bench, looking out at the light sparkling in the water, lots of water imagery and nature imagery. And just ask them to continue, right? Think about the images, bring in all of the sensory elements. Think about the colors, right? The sounds, the aroma, right? What they feel physically in terms of textures at the sand, clothing, noticing then how they feel emotionally, right? And so the whole time they're tapping, alternating rhythmically, right? Each shoulder. Right? And their eyes are closed or their gaze are lowered, and you can really visibly see your clients begin to relax. And then with protective figure or nurturing figure, we ask, I'll just give an example of nurturing, right? Because that's something that was a missing experience for many of our clients with complex trauma. And so we ask them to identify anyone in their life. My client the other day said, my teacher. She said, I remember being in the first grade and we all sat in a circle and we had to answer questions. And my teacher had this, colorful, glittery box with different trinkets and toys that she would give us as a prize. This is what my client said. And she said she answered, she's super smart. She answered the question correctly. The teacher came behind her, gently placed her hand, the teacher's hand, on my client's shoulder and gave her the toy. My client is 49 years old and remembers that as the very first among very few experiences of nurturing. She's like, I don't remember that from my mom or my dad. But I remember this teacher, right? So let's think about the characteristics. What made this individual, this figure, nurturing, right? Do they help you feel seen, loved, understood, right? And for our clients who can't come up with a figure, we say that's okay. Can you imagine yourself nurturing someone else? Even a pet, right? Sometimes that's the best nurturing experiences, right? So we ask our clients to then identify with that part of themselves that is nurturing, right? And so you sort of get the idea. But I find adding in the tapping, the butterfly tapping really does deepen the experience. And so I also encourage my clients to use resources, play around with different resources and use it in between sessions, anytime they're feeling disturbing emotions or even a sense of shame. And so I want to share some techniques for intrusive thoughts and feelings and body sensations. Again, something that many of our clients experience quite a bit. So even despite, just thinking of us, right? Even despite our best efforts to avoid these things, we will encounter situations that can be quite triggering and that can generate really difficult emotions and unsettling physical reactions. So somatic therapy practices offers so many different techniques for our clients and for us to begin to work with those emotions, not feel afraid of those emotions, and for our clients to begin to even process attachment related wounds and trauma. So, two particular techniques that I want to share with you. The first is 5-4-3-2-1. You're probably really familiar with this technique. This is considered a grounding technique, right? I often share this with my clients who experience high anxiety or panic. It is well regarded as one of the best tools for addressing panic attacks. You want to teach it to clients before they have one. So 5-4-3-2-1 helps to soothe that alarmed limbic system. That limbic system that I say to my clients is on fire, and it helps clients to reconnect rather to the present moment when trauma triggers arise. So I find that grounding techniques, and there are many others, are really beneficial for our clients with complex trauma histories because, again, it helps them to ground themselves in the present moment and really anchors them into a sense of calm that's so crucial for our clients who struggle with that because of attachment-related anxiety and insecurity. So 5-4-3-2-1 is so simple. Name 5 things that you can see, 4 things that you can feel, 3 things that you can hear, 2 things that you smell, right? This clients will struggle with this one, but you can see how it's moving from limbic system activation to frontal lobes. You kind of have to think about it, right? It gets progressively more difficult. What do you smell? I'll say to my clients, is there lotion? Or do you smell a hint of a candle in my room, right? Or air diffuser, lavender is what I often use. I use orange as well. So then one thing you can taste, that can be your sandwich from lunch or an old piece of gum or toothpaste, right? So 5-4-3-2-1. Another way to, from a sensory perspective, ground clients when they're activated is having them hold a piece of ice or eat something that has a strong sour taste, like a lemon head or something like that, or placing hands in water. So those are just a few examples. And then I want to share with you some, let me go back. I'm so sorry. Pendulation. Let me introduce that very quickly to you. So this is a wonderful, wonderful exercise that was developed by Peter Levine, who is, just well known in the somatic world. He developed somatic experiencing. So this is a way to have our clients practice changing their state by noticing a mild disturbance and then going from that disturbance to a place of calm or relaxation, similar to a butterfly's wings, right? We're oscillating from one state to another, So I want to share some steps with you on how to do this particular technique. And this is sort of the script that I use. Feel free to make it your own. So this is also considered I think I mentioned it's sensory or somatic experiencing technique. So the therapist leads or guides the client to think through some experience that might be disturbing. And so let me back up. You're oscillating between something that's upsetting to something that is joyful or hopeful, right? So think of the contraction and expansion of a butterfly again. So the way that I introduce this technique to clients is, hey, I invite you to bring up something mildly disturbing. So the very first time you want to introduce this exercise using something that's not on a scale of 0 to 10 out of 10, right? I think 5 is probably good or even less just to start off. And a client might say, oh my gosh, my morning commute was horrible. I thought that I was going to be late for work and I was going to present this idea to a manager that I'm not even sure gets me or understands my vision. And so that was bringing me a lot of anxiety. And then traffic was awful. So something like that, right? So bring up something that is mildly disturbing, maybe a recent irritation, an argument with your partner, your spouse. Focus on how you were experiencing that, but bring it up in the present moment. And oftentimes, if it has any level of charge, you'll notice that they can sense it, right? And then scale it from 0 to 10, with the hardest or most intense thing being at a 10. How would you scale it? Right. And so again, it's probably helpful to start with something at a 5 or lower, and then slowly have clients to experience and then share what's coming up for them. Right. And then this is where I caution therapists to just pay attention to their clients and also remind clients that if it's too big, if it's too overwhelming, we probably need to take the edge off a little bit, right? We probably need to just notice even the edges of the sensation, not the full intensity of it, the full charge. And then I'll say something like, I invite you to notice a place in your body that doesn't have that charge at all, that feels completely different. It may feel neutral or calm or good. And I'll even point out it could be your pinky finger or your pinky toe. Just notice that. And then I'll even ask them to give me a feeling word, right? So some of the words that they come up with: calm, neutral, warm, light, still, expansive, flowing, peaceful, joyful, hopeful, right? Somewhere in your body, you're feeling that. Could be just the tip of your pinky nail, right? Or the nail on your pinky. And then I invite clients to go back and forth. I invite you to go between those two places, right? I'll even have them name the disturbing event, right? Rigid, cold, upsetting, jagged, like glass, some people will say, harsh, and then calm, light, peaceful, flowing, joyful, right? Neutral, right? It could be fear and calm, could be hard and easy, could be dark and light. So pay attention to what happens as you flow from one state to another. And I will ask my clients, it's coming, to notice if there is an automatic release from your body. Does your body automatically release something in the form of a deeper breath, a sigh, or a yawn? That is a somatic release. So my body just did that on cue, right? And when the client appears to be complete with this oscillation, it can only be a few minutes. I've done it at the end of sessions in 3 to 5 minutes. You can then ask, what was that like for you? What are you experiencing? And the client can then report the experience, and then you can encourage them to do this in between sessions. So that's one of my favorite somatic exercises. So now let's talk about sensory motor modifications for self-regulation. Again, self-regulation is a big deal for our complex trauma clients. So affect dysregulation is a component of nearly all mood, anxiety, and trauma-related mental health conditions. And studies are indicating that there is a connection between affect dysregulation and experiences of early childhood trauma and neglect and other attachment wounds. And that makes sense to us. So sensory motor psychotherapy is a body-based model developed by Pat Ogden as a way to really work with the subcortical issues or region of the brain that can really be, I think, easily integrated into EMDR or some other trauma processing model and really all traditional psychotherapeutic approaches. So there are so many different techniques associated with somatic therapy. One core principle around somatic therapy is the development of somatic awareness. So, body scanning is one of my favorite somatic awareness techniques that involves paying close attention to the physical sensations throughout your body by mentally scanning yourself, right? You are noticing areas of tension, restriction, pain, or aches. And then I always say to my clients, the goal is not to get rid of it. And they're like, what? I thought that should be the goal. I'm like, no. Don't put that much pressure on yourself, right? The goal is to just get to know it, right? As Deb Dana says, befriend it. She's talking about the nervous system, but it applies here too, to get to know it, because then that helps us to learn how to better manage it. So this is a whole protocol. It's easy. This is something that I think can be easily adapted. You can look it up and adapt it. So I won't go through the whole thing. But one of the questions that I get asked by therapists during these trainings is, how long should it take? Well, a body scan can take 20 minutes. I have had it take 40 minutes, right? But most clients, especially in the beginning, will only be able to tolerate just a brief amount of time. So really 5 minutes or less. It helps our clients to be more attuned to their bodily sensations, which helps to reconnect the mind and body. Remember, the goal here is integration. And then finally, we can also just share with our clients that there's a host of somatic resources, such as getting outside, taking off your shoes, feeling the ground under one's feet. If you can't get outside because maybe it's rainy or cold, really focusing as you're standing or sitting on the bottoms of your feet or your backside, touching the chair, placing your hands over your heart, right? Lengthening your spine, right? There's so many different simple somatic resources that can be incorporated in the work that you do. And then finally, self-compassion, right? I couldn't wait to get to this. So shame, especially chronic shame, is again the most destructive emotion and is also believed to be stored in different parts of the body. And the way that it presents in our clients is in physical sensations, again, tension or tightness in the throat, discomfort, pain or irritation, feeling like your stomach is doing is in knots or doing somersaults, as one of my clients said, or on a roller coaster. So studies show that self-compassion has many, many different benefits, right? It reduces the frequency of self-criticism. It lowers our stress hormones, because if we're constantly experiencing self-loathing and criticizing ourselves, we're more stressed out, right? It can begin the process of healing any missing experiences from early caregivers, the shortages of caring and compassion from the significant people, the trusted other in our client's childhood. So I'm a huge fan of compassion-focused therapy, CFT, for ourselves as therapists and also for our clients. Some of the key principles that I use in my work within this model revolves around helping clients to put themselves on their own to-do list, right? To care for themselves the way that they care for others, to prioritize their own mental and emotional well-being, to become more sensitive to the distress flares, the cues of distress that their body gives them, and then to respond with warmth and understanding, right? That experience that they did not get. In essence, a lot of this aligns with the reparenting approaches that are really common in trauma processing and trauma healing. So shame puts us in a freeze state, right? Somatically, which hinders our ability to think and to relate, and our body reflects this, right? You may notice that your clients who deal with shame show up deflated or slumped over, or the posture is off. They're hiding their face. If you're doing telehealth, they're averting their eyes. Even if you're face to face, they're shrinking themselves to appear smaller, right? And what I say to them is this, a lot of my clients, it's as if your body is pulling you away from the thing that you want the most, which is connection, right? So we want to offer a different experience. So because shame exists in the mind and the body, I like to work with it somatically. And so, very similar to nurturing figure, peaceful place resource, I ask clients to get in the mindset of self-soothing. We talk about that. We practice that. And then to bring in a self-compassionate component, I ask them to bring to mind the feeling, the experience of being with someone, right, who they know cares about them. A friend, a family member, a pastor, or, right, someone from their faith tradition. It could be, Jesus or Buddha, right? Oftentimes with our clients who have complex trauma histories, it's us, right? They're bringing up you as the therapist. Gosh, what would Dr. Chinwé say is what my clients say. That means you've done your part with regard to therapeutic alliance and attunement. And so when you come up with that figure, come up with that experience, soak it in and notice what that feels like in your bones, right? That feeling of mattering to this person. And do that especially when you're feeling your most vulnerable. And then finally, this work that we do, my friends, is difficult in this day, in our current world, our current reality. It feels like it's heavier because our clients are experiencing a lot of hard and heavy things. So burnout and exhaustion are real. And it's required of us, right? It's an ethical code for us as therapists to take care of ourselves. So I invite you, as you do this work, to continue to cultivate rhythms of rest. Adequate rest improves our ability to adequately offer compassion to our clients and to ourselves. And also incorporate some of these practices, because the more that you're able to do it, you can even share with your clients, hey, this wasn't easy for me at first, right? And that's a form of compassion that heightens our own compassion when our clients are struggling or they don't do their homework, right? And then spend time outdoors, spend time with loved ones, take the scenic route. And remember that healing is ongoing, right? The process of helping clients to heal from trauma is ongoing. So recovery must be ongoing. So this is a photo of my dear friend who's an organizational psychologist. She hadn't been to the spa. She'd been traveling around the world, working so hard. And I said to her name is Tanya. She's given me permission to share. I said, when are you going to take care of yourself? When are you going to pause? When are you going to cultivate a rhythm of rest? She's like, I'm going to get there. I'm going to get there. And then she sent me she sent me a text and she said, I'm at the spa with my twin girls. I finally made it to the spa. And I said to her, send me a picture. I'm not sure that I believe you. And she did. And I was really happy. Friends, thank you so much for your time and your attention. Please be well.